welcome to our second to last grand rounds of the season. We've got preventing firearm injuries and deaths for you today. And our speakers are Therese Hansen from the State Department of Health. She manages the Injury and Violence Prevention section with the state. And we have Sergeant Jordan Ferguson from our own Spokane Police Department presenting today to let you know about the larger impact for Washington State in terms of what we're seeing in terms of firearm injuries and deaths at the state level. And then Jordan's going to let us know about some things that are happening locally and some local measures that are taking place.
So good afternoon, good Friday afternoon to everybody in this wonderful spring day. And I want to thank Dr. Tresser for inviting the State Department of Health to participate in the grand rounds here. As I was introduced, I'm going to be speaking today about the, there we go, 1 second. There we go. Firearm injuries and death from a public health perspective, and a little bit about our public health approach to it. I just want to show you this. Oh, wait a minute. The last one that I showed you. Wait a minute. I don't seem to be able to get backwards. Anyway, oh, here. I put this one in for those Master of Public Health students who might be interested in working in Olympia when you're finished. This is a shot of our office, so we welcome you to join us when you finish your studies. Very exciting for us to know what you're doing out here. So, violence is a major public health issue. It's a big problem. I've been invited to speak on this subject. I'm going to share a fair amount of data with you because public health is data-driven. So this is a declaration from the CDC. Violence erodes entire communities, reducing productivity, decreasing property values, disrupting social services, and making people feel unsafe. This is very, very important, and this is a statement from the CDC that crosses all violence, whether it be intimate partner, sexual, domestic, child abuse, elder abuse, homicide, or suicide. So a lot of what's applying today, that we're talking about today, is also going to be applying to all sorts of violence that we endure in our society. Our overarching role as public health officials is to protect the health, safety, and the well-being of the entire population. So in our work and in our section, which is Injury and Violence Prevention at the Department of Health, we strive to look at the maximum number for the greatest benefit of the population. But I want to make sure that you understand that every day in our work, we understand that behind all the violence and all the injury are moms and dads and children, sisters, brothers, families, and communities. So we make sure that we never lose sight of this. This is a really important principle, and we know that there's a face behind every piece of data. So even though I'm going to show you a lot of data, I want you to know that we understand that it's all a person that's behind this. Violence is also costly. This is also from the CDC. 19,000 people were victims of homicide in 2016. 45,000 people died by suicide. The economic costs are, as they say, staggering. $57 billion related to suicide and $30 billion related to homicide. The emotional tolls on victims and families and the criminal justice system are immeasurable. And then, of course, is the really harsh part, and that is those who survive a violent experience or who have had a loved one experience the violence really suffer, and trauma can last for a very long time. I think we've seen that this past week as we've looked at the Parkland suicides and the suicide by the father related to the Sandy Hook, the death of his daughter. Data is really important. As I said, in public health, it's the foundation of public health practice. And so is surveillance. So surveillance in the public health arena, and I think most of you public health students probably know this, is not surveillance by FBI or Alexa or Facebook. This is surveillance in the context of ongoing systematic collection, analysis, interpretation, and dissemination of data to reduce morbidity, mortality, and to improve health. This is the Association of State and Territory Health Workers description of surveillance. We spend a lot of time in it. As Master of Public Health professionals, you will breathe it, you will yearn for it, you'll dig into it, you'll chew on it, and eventually you will respect its power. And I want to encourage you to not run away from it, because even those who are a little fearful of it at first embrace it and understand the importance it is to their work. One second here. Oh, I went too far here. Oh, sorry. Wow. Oh, how am I backing up? There we go. Hang on. Sorry. One more. So we start typically in injury and violence prevention with the CDC for tools and for data. And if you opened this particular, sorry, that's not working very well. If you scroll down Washington here, these are CDC maps that are all automated, and they will pull up all sorts of data for you. If you clicked on Washington here, you would see that in 2017, we had 849 firearm deaths in Washington state, and we have an 11.1 rate. If you open the CDC tools, you can get all the data from previous years, and it's very interesting to look at. It breaks down by homicides and suicides, as well as other types of deaths. So here we're going to look at homicide and suicide in Washington and in the United States for the last 10 years. And the reason I pulled these two out is because almost all firearm deaths in Washington are one of these two. And you will see that we have in 2017 here, we had 1,292 suicides, and we had 264 homicides. We are always ahead of the national rate for suicide, and we have been consistently lower for homicides. This slide talks to us about the methods used in homicides and suicides. The firearms are in green and obviously dominate the method used in both homicide and suicide. The firearm-related homicides are 75% of all U.S. homicides and 62% in Washington in 17. And you will see, and this is consistent, in 2017, it shows about the same between Washington and the U.S. rate, and that is pretty consistent across the board. I do want to point out that firearms are definitely the most prevalent method of these deaths. But in certain populations that can shift. For example, there was a recent study that came out in the gay population, and it looked at gay males and lesbian suicides, and suffocation was the primary method there. So in public health, we don't just cut with the broad swath. We have to look at each population. So we have different systems that we use to get to that information. Here, I'm going to show you, I don't know how many of you are familiar with the ACH regions. Looks like I've got some nods here. So these are accountable communities of health that we have 9 in our state, a relatively new concept. And their job is basically to improve the health equity, align health resources in accord with local health improvement plans and initiative. And Spokane is in the Better Health Together ACH. I'm showing you this because I'm going to show you some data regarding that. So let's look at the firearm deaths in U.S., Washington, ACH, and then Spokane County. So you can see here that the ACH has the higher rate, and Spokane has a higher rate than Washington in general. And then you'll see here on the blue is the United States rate. So in the ACH, we're looking at numbers of 85, in Spokane, number of 68. That would be in 17. And then in the state, like I said before, is 845. It's really important for people, especially when you're talking about public health and going out to communities, to show people themselves and their communities. So we like to look at what's relevant to each of you. So that's why I pulled the ACH and the Spokane County work here. Here we have firearm suicides and homicides by age. The other part in public health that we spend a lot of time on is demographic work. And you can see here that the highest rate of suicide is among those who are 65 and over, primarily male. And men in the middle years, we call it basically in that 25 to 44, 64, is a major population for suicide. The suicide by men in the middle years and by firearm is a major public health issue, and it's one that we study quite closely here. Let's see, on the homicide part here, we show on the suicides increasing firearm usage with age, and then in the as we're looking at the homicide piece, firearms are used less frequently as people age. All right, and here it is by sex. Again, males die at a much higher rate in both firearm suicides and in firearm homicides than women. 3 to 1 is the ratio for men to women in suicides. In the accountable community of health and in Spokane, again, a little bit higher here than the, actually fairly significantly, here in the ACH compared to Washington State, and then also in Spokane County. And here we go by race. So those are our 3 primary demographics that we look at: age, sex, and race as an initial threshold. And as you can see here, the highest rate in homicides in the US and in Washington are the Black population, and in suicides is the American Indian Alaska Native population. What we do in public health, because sometimes rates can be so confusing to people, I try, at least in most of my data, to make sure that we've also added the numbers so that people can really understand both sides of that equation. And here's, this is just a crisp snapshot in case anybody needs to use it of just Washington data going forward. It removes the accountable community of health and Spokane and the US. And I just want to show you here, in 2016, when we're looking at firearm deaths, we had 512. We are now at 637 in 2017. Preliminary data in 2018 is also showing another uptick. So of these, of the 163 increase between 16 and 17, 125 were suicide. Again, this is all firearm usage here. All right. I want to just break 1 minute here on childhood firearm injuries. This is a study in 2017 that is probably the most comprehensive study that I've seen on firearm injuries among children. Here we had, you can see boys who were, are 82%, older children 13 to 17, Black and American Indian Alaska natives are at most risk for firearm-related injuries. Youth, young children, the perpetrators were 25 years or older. They were killed in a home, and they were a part of an intimate partner violence cycle. Older children, perpetrators were close to their same age. They were killed in the home or on the streets. And then a major part of that was either a crime, a drug, or gang-related violence. And this is the other piece that I think is pretty interesting. In your previous grand rounds, my colleague, Pat Justice, talked about RUCA codes. These are Rural Urban Classification System. It's a piece of what we use to breakdown by our areas. Oh, okay. All right. Sorry, I'm running really slowly here, I guess. We always want to look at what's going on both rurally and urban. And so this is some of the data that we venture into. And we also use hospitalization data, and you will see it's truncated here. That was due to a glitch in a changing of the international classification system. But we have we had of the 700 and, what do we have? We had 7,425 people were hospitalized between 2016 and 2017 for for intentional self-harm injuries, but only 152 of those were caused by a firearm injury, and that's because usually when there's a firearm involved, they are not making it to the hospital. And I'm going to skip that one. So one of the other major systems, and this is new to our state, which I hope will be of value to you as you're going forward, this is the National Violent Death Reporting System. What this does is a CDC system that pulls together for the first time the why of how, these violent deaths happen. So it looks at circumstances, it looks at characteristics, it really delves down to something other than what happened when, what was the time. And this system is a very robust data piece that's really starting to get some traction here in the United States because the states are developing enough of the data to actually tell us things. And one of the things that they told us just recently was there's a lot of focus on whether or not in a suicide situation a person has a mental health problem. Well, what they're learning here is that in recent data that they looked at from 27 states, 54% of those people did not have a known mental health problem. And so they're not going to come into a clinical or a behavioral health situation. And so how do we prevent that when that's not how we're going to be able to help them? We have to do other things. So this is a very, very powerful system that is growing, and we have joined it in Washington State just in 2015 here. And the green here is where we started with. So we have 2 years of data from the dark green, which is about 70% of the deaths. Spokane, now we've just finished our second year of the Spokane data as well. Your medical examiner in this county and law enforcement is helping us with this, and it's a really, really interesting system, and it's worth looking at if you're doing research or trying to answer questions in this regard. I'm going to skip over these. This is the data that we're pulling right now from Washington State with respect to firearm-related suicides and homicides. We are seeing that in most of them, most of the suicides and in most of the homicides, a handgun was involved versus a rifle, a shotgun, or something that is unknown. So I think I better skip this piece so that I can go to some of the things that we're doing here. So we have a suicide prevention plan. As you probably have deduced from this presentation so far, firearm suicide is the major issue here. With 1,292 of the suicides by firearm last year versus 224 homicides, we are very focused on suicide prevention and firearms used in suicides. So we developed the suicide prevention plan. It's the first across the lifespan suicide prevention plan mandated by the legislature. It was done with people across the entire Washington state. Came up to 4 strategic directions, and I brought some copies of it. You may want to take a peek at it. But this is a very important guidance for us. We adhere to it as we're trying to develop evidence-based programming and solutions to deal with firearm suicide and homicides, as well as all other suicides and any other injury and violence related to suicide. We look at, in public health, risk factors. I'm going to pull one right out here, and that is isolation. Risk factors are key to public health. Primary prevention is our golden ring. We want to prevent injury and violence from happening. When we can't do that, the second stage is secondary interventions, and we look at the risk factors to build up the evidence base. One of the risk factors here that applies to firearm as well as all sorts of violence is isolation. Last week, when the deaths happened at Parkland and with the Sandy Hook father, the college professor from Boston College purposefully said that the major thing is isolation and lack of connectedness, and we really have to get better at this. So we look at the risk factors, and then we look at the protective factors. And the two I bolded here were the strong connections to family and community support, and then the clinical interventions and help in a community for help seeking, even if it's not clinical, because as we saw, 54% of suicide victims did not go to any sort of clinical intervention. Skip that one right now. So the other public health approach piece is very collaborative. We have to work with all sorts of groups. We work with tribes, we work with all the health agencies. At the Department of Health, our Assistant Secretary chairs the Action Alliance for Suicide Prevention that looks at firearm deaths as well as all suicides. This is a high-level task force, and we are very engaged in trying to work out all pieces of all priority of populations, all methods, and all evidence-based strategies that we can develop. And I'm going to reducing access to lethal means because of the firearm deaths and the suicides and the homicides. There's a lot of work being done around Washington State on safe storage. I'm sure you've come across it. And this is the Safer Homes Coalition that is working very hard to work with hunter firearm retailers. They have a member of the Second Amendment Foundation on the advisory board, I think is also a chair. And they basically are trying to educate and to provide locking devices. In fact, I think they're going to be in Okanagan and in Republic, Washington very soon. So they've been doing this work for about 2 to 3 years now, really focused on safe storage, not only as to firearms, but also as to medications. I'm going to welcome you to take a look here at our firearm fatality and suicide prevention report that just is hot off the press. When our suicide prevention plan was released in 2016, the governor released it along with his executive order 1602 that called on all of us to take a real concerted effort to reduce firearm fatality and suicides in Washington State. And our new report shows all the work that's going on around, I shouldn't say all, a lot of the work that's going on around the state. And it also points out our milestones. So I welcome you to look at it and to give us a call. Let us know what you know that's going on that we might want to add to it. This is, we have Therese is my colleague here, and Therese is chairing. This is a new legislative requirement for reducing suicides in the agricultural industry. So we have just set this up. Therese is running that program, and we are working with WSU on a pilot project right now in Skagit County. And it is primarily focused on looking at deaths within the agricultural community. And we have websites, we have all sorts of information tools, because that's the other part of the public health approach, information, education. So it's data, it's risk factors, it's shared risk factors, it is collaboration, and then it's information and education. And then we have a whole bunch of resources. Okay, all right, thank you.
So just click on this, huh? No, I'm gonna use the same microphone.
Oh, yeah.
Yeah, I'm not gonna.
Oh, you are? Oh.
Yeah, So look at that. Hi, thank you everybody for coming. I'm Jordan Ferguson, Sergeant with Spokane Police Department. I am part of the Spokane Police Department's domestic violence unit. Spokane puts a lot of input and resources towards domestic violence. We have 4 officers, 2 detectives, and myself in the unit. We are set up as what we call a family justice center, which means we are in cahoots and we're in the same room with domestic violence advocates and prosecutors. So the flow of information between the 3 branches is just incredible. And we have several phenomenal stories about what has happened because an advocate was able to get information or make a connection with the victim, or a prosecutor heard something, was able to tell an advocate. It's a fantastic story. We have some good success. Our main model that we do in our domestic violence is called focused deterrence. This came out of originally High Point, North Carolina, and then Chula Vista, California did another study on this focused deterrence. And what we are doing is we are confronting the offenders, the defendants, before their first court appearance in jail. And we're explaining to them that domestic violence is not like anything else. It's not like you're going to get stopped shoplifting here and stop shoplifting there. Nobody will really know. It all funnels through our department, our division. If you don't knock it off, we're going to start talking to prosecutors, talking to judges, and start upping the consequences to get you to change your behavior. So that's what we focus is on, the behavior of the defendant, the behavior of the batterer, which kind of leads into what we do with firearms, because we're focused on the behavior of the person around the firearms. Firearms by themselves really don't do much when they're locked up in a safe and they're unloaded, and they're just not going to hurt anybody in that. You put them in the hands of somebody that's not in the right state of mind, and it can be devastating what happens with that. So big thing that comes up when you start talking about firearms, domestic violence, is this is America. You can't take my gun away. We got a Second Amendment. You can't infringe that right to take that away. My biggest critics, the biggest people I have to battle, mostly it's other law enforcement. And they said, well, you're just trying to come in and take all the guns away. And it's like, no, we're not. And for years and years and years, we have had rules that if a person has a certain kind of behavior, the state has decided they should not be able to possess a firearm. We don't let convicted felons possess firearms. Since the 70s, we don't, or 90s, we don't let domestic violence batterers possess firearms. We don't let people that are seriously mentally ill possess firearms. We prohibit people that are addicted to different substances from possessing firearms. So there have been rules for years and years on who can and who can't have a firearm. We don't let 15-year-olds run around with semi-automatic weapons. You know, they can go to a range, they can have supervisor stuff, but there's been rules for years. So we're not doing anything different. We're just trying to take a proactive approach. And when somebody's engaging in behavior that increases the risk to themselves and to society, we're going to try to step in. So what we're looking at is an order. We call it an ERPO, Extreme Risk Protection Order. Nationwide, they're known as red flag laws. First one came out of Connecticut after a mass shooting at the lottery office there. This is an order that a law enforcement agency or a family member can petition a court to prohibit somebody from possessing or purchasing a firearm. And you look at it, and it's like there are sometimes a person could have a perfectly normal life, everything's fine, and there's a trigger moment, and at that point, we don't want that person to have a gun in their possession. We're going to try to prevent bad things from happening. So the RCW, Revised Code of Washington on this, is when an order is issued for a defendant, a respondent to surrender a firearm, it is for an immediate surrender of that firearm. When the law first came out, people were really confused. They said, well, oh, geez, you know, you can't just walk up and give a guy a piece of paper and take their guns. Well, I was like, well, no, actually we can. It'd be like calling somebody up and say, hey, we're going to come arrest you in about, I don't know, 2 or 3 hours. So just stay right there. We're going to come do it. It doesn't work. The thought process doesn't make any sense. So we're, getting law enforcement keyed up on that. We've had to make some changes. Somebody read the policy wrong at the beginning. So we're recovering from one of our mistakes. We do make mistakes as law enforcement officers, in case anybody wondered. We don't try to, but it does happen. So the extreme risk protection order, explain that. So the petitioner is the person that's going to court to issue an order. And this is where we go back to the Second Amendment and the rights, and you're just being a gun grabber and taking guns away. Everything here is done with due process. So a law enforcement officer, a family member by themselves cannot go and take that gun away. That would be unlawful. They have to go to a court. They have to convince a judge that there's a danger going on here, and the danger is severe enough that we should take the guns away from this person. Seattle's been on top of this a little bit better than we are. They had a good head start, and we've done a few here in Spokane. So the family members, pretty close to the same definition of family members in domestic violence laws in the state of Washington. And we have our due process. So that means we're going to make sure we're not violating this person's right. We have a neutral third party, that is the judicial branch, involved in all this. So the petition, the officer will come in and explain to the court that this person at this time presents a danger to themselves or to somebody else by having a firearm in their possession or the ability to get one. And they have all sorts of nice forms that we fill out, and we will explain to the judge. The judges here have been very thoughtful on issuing these extreme risk protection orders. They're cautious because they do not want to jump in and violate somebody's rights as well. So we have to go through and explain everything that we have going on, what the risk is, what the behavior is, to convince the judge to issue the order. After an order is issued, to take a gun from one of these people, the person has the right to present their side of the case in front of the judge within about 10 days. So that neutral judge is going to get to hear both sides of the story. So we're not doing anything bad that people think, but we're just trying to take the gun out of the mix of a volatile situation. So here's some of the reasons that we look at. Threats of violence. Our last one, the gentleman was threatening to go down to his workplace, shoot up at his workplace. Mental health issues, suicidal, other orders that are out there. We want judges to know whether this person's had a domestic violence conviction or not. We try to explain everything, put all that information into our petition. So I did one, my first one last year. It was a domestic violence call. Husband and wife arguing. The officers show up, and the officers, Spokane Police Department, all of them gone through a 40-hour crisis intervention team training. So they're really good at talking with people and dealing with things. And then a good chunk of the department has also gone through an enhanced crisis intervention training as well, where they learn about things like motivational interviewing and things to get people to change their behavior. And you watch some of these body camera videos, these officers talking to people, and they just do a phenomenal job. So the officers respond to the call. Husband comes out, meets them, and just admits that things are really, really tough. And the officer just kind of backs off a little bit and lets the guy explain. And the guy explains a little bit more and a little bit more. And pretty soon the guy says, yeah, it's really bad. And the officer says, well, how bad is it? Well, we were fighting the other day, and I went and I grabbed my gun and put it to my head. And the only reason I didn't pull the trigger is I didn't want to disappoint my family. So anybody that studies conversations with people and how people interact, when somebody takes possession of that gun and talks about putting it to their own head, that is about as serious as a comment as you can get out of somebody. And then the husband says, yeah, the guns probably shouldn't be here right now. Can you guys take them for safekeeping? And the officer said, yes. Which was great. It was absolutely perfect. So I learned about this information. The next day I went through, looked at it. I went back, watched the videos with the officers, watched them talk to her, watched them talk to him, and had just had training on the extreme risk protection orders. Said, by golly, I think we got one here. And went through and looked at it. And the key thing that was on this is when the officers explained to the wife that they couldn't tell whether or not a crime had been committed, which is what we need for probable cause to make an arrest, and they were going to have to leave. She asked them 3 separate times if they were going to take the guns. And the way she said it and the passionate way she said it is when he went and took his gun and put his gun to his head, there's no doubt in my mind, his nose was touching her nose. And he was threatening to put suicide right in front of her to mess her up. And that's his level of mindset on that. So we petitioned the court. Court said, yeah, that looks pretty bad. Let's do it. We set up our court date for 2 weeks, and we get in there, and the husband comes in and said, well, I can understand you guys hanging on to the guns for a couple months, but a year just seems like a long time. And Judge and I look up and make contacts, like, yeah, we got it. And basically that's what it was. He understood that he shouldn't have the guns. He just thought it, because that's what the extreme risk protection orders keeps him away for a year. And he just didn't want to go for a whole year. And that was that. So that was our first one that we ran through on that. So why are we concerned, domestic violence unit, about guns and firearms? And it's because of stuff that Therese talked about there. Is a firearm is the most lethal thing to a woman in America. It's just nuts. And I mean, here's some facts here, and I will not be able to regale you with statistics as she did. That's why I use little bullet points and pretty pictures. And I have to throw out the pretty pictures. I have an intern working in our office from Whitworth University, and she's like a whiz on PowerPoint. And I say, hey, Madison, I'd kind of like to do, and she goes, and it's all done. And I say, oh, this is cool. So Madison Gabriel gets full credit for how nice this looks. So yeah, the guns are used, and they're not just used to kill, they're used to scare, they're used to abuse, threaten, intimidate, just like I put my gun to my head. And then if once the gun's out there, once a woman's threatened with a gun, then they're more likely to be killed with that gun. And so this came out of some information from Battered Women's Justice Project in a publication called When Men Murder Women. So this stat here came from research from Dr. Jackie Campbell and other researchers at Battered Women's Justice Project. It's the research of women in battered women's shelters, and they were getting assistance. But they looked at the number of women that had been threatened with a gun, no shot fired, not assaulted, but just threatened with a gun. And that's 4.5 million women alive in this country right now have been threatened with a firearm. That's just a lot. And that's the stuff that we're trying to stop and bring that to a screeching halt. So Seattle was kind enough to share some of their examples of what happened. This one, he tried to commit suicide, shot himself in the chest. Officers arrived. We have a joke with police and firefighters because something bad's going on. The police have to go in first to make it safe for the firefighters to go in so that they can go have their chili cook-offs and sleep on duty. It's a long-standing feud with police and firefighters like that. So here it is. You have a guy that tried to kill himself, shot himself. Officers get in there. First thing they do, combat training, and they're trying to stop the bleeding, get it going, and they get punched in the face. Then you run in to save somebody's life, and you get punched in the face. We expect that. He wouldn't punch a firefighter in the face, but yeah. Anyway, they save him. They get him to the hospital. They find that gun, find another gun, and you see at the bottom, this guy had in his mindset, his dad had committed suicide at the same age, and he had convinced himself that he was going to have to commit suicide at the same age. They filed the extreme risk protection order. They got all the firearms away from him, and so far he's still around and kicking with that. Another suicidal situation. And this one actually went and purchased the gun, tried to do it, and didn't have the strength to pull the trigger. And that's not physical strength to pull a trigger. That's mindset strength where he couldn't do it that far. So they were able to do that. A few months later, he got the nerve up and said, you know what, I'm gonna go ahead and finish it this time. Went to go buy a gun in the neighboring town of Linwood, and it popped up with that national incident background check, and it stopped the purchase. He couldn't buy it, and then they arrested him for the gross misdemeanor crime of trying to purchase a firearm when you have an extreme risk protection order on it. So they put some new laws in there with that. So the penalties, so with our extreme risk protection orders, we have your failure to surrender the firearms, failure to comply with it, false reporting. This is one people think, and they think there's this huge wave of false reporting. People are making stuff up just to get them in trouble. And it's not like that. It's a very minimal part. There are false reports, but in this law, we passed it in the state of Washington, it is a penalty, a gross misdemeanor, if you make stuff up to lie on an extreme risk protection order to get the gun away from somebody else. That's a good, strong law. We don't have that law in many other things. You know, you accuse somebody of robbery, you're not going to get charged with the crime, you know, unless you do something very, very egregious. So you attempt to purchase it. And then for the other court orders, if you possess a firearm while you have a domestic violence order out against you, that is unlawful possession of a firearm, which is a felony. Forms, Washington State courts have all the forms up there. The extreme risk protection order brochure does a nice job of explaining everything that's up there. So what we do is we, you know, fill it out. When I had to do that first one, it was kind of an eye opener for me. Actually, about every other week for me is an eye opener and an aha moment. Either I was really dumb when I started, or I don't know what's happening. But I sat down and I'm looking at this order. I'm going to fill it out. Holy cow, this is a lot of stuff, and I want to make sure I get the right things. And I mentioned we're in a family justice center, and we're co-located with advocates and attorneys. And I said, I'm going to go get myself an advocate. And so I walked across the hallway and got an advocate and said, hey, can you help me fill out this order? And they said, sure, Jordan, we'll help you fill out this order. Got it filled out. That looked pretty good. That was, yeah, it all looks great. I go, now what do I do? Well, you have to go to court. I said, oh, Jordan, do you want me to go to court with you? Yes, that'd be great. So I got an advocate to take me all the way over to court. And the aha moment for me was I hadn't been assaulted the night before. I hadn't been beat up, tossed out of my house, strangled, all these other things that happened. I was in a pretty calm, I don't even think I watched a good TV show the night before. But I could not imagine having had that sort of beating and then to come out and do like an essay test for college and go in front and present it to a court. And now I look at orders, and when they don't make sense or the victim looks like they're a little confused in this whole, it makes a whole lot more sense what they're having to go through on that. So that was my aha. So with what Therese said on things, collaboration for us is absolutely huge. Most people don't realize that we as police really can't make anybody do anything. Everything is done with cooperation. If we didn't have the support of the community, the trust of the community, we would get absolutely nothing done. We're a real small sliver out there, and that's why we're working with other agencies. We work with the advocates, prosecutors, trying to put everything together to cut down on these firearm-related deaths. Thank you.
All right, wonderful. Thank you so much, both of you. Let's have some questions. And for our online folks, we do have a chat box that you can go in and type in your questions. So you can ask questions from online as well. But we'll start with the folks in the room. Comments or questions?
So when you go to give the first warning for someone that's showing signs of domestic violence, or there's some report, is there also a system in place for the woman? And that might be, I'm sorry, it's genderism right there, but whoever is experiencing the violence, that they have someone that they can talk to in case the situation escalates without the intervention and removing the person or the instrument that might cause the violence?
Absolutely. We use something called the Fatality assessment program in Spokane, and Spokane County does as well. It's a series of 11 questions developed by Dr. Jackie Campbell that can actually dictate the risk of a woman suffering future violence or homicide by their intimate partner. The officers are trained at the time when they believe an assault has happened to go through the questions. If the victim screens in, which means she answers yes to some specific questions or a bunch of the other questions, at the scene right there, the officers will pull out their cell phones and they will call an advocate, put the advocate on the phone, explain what's going on, hand the phone to the victim so the victim can start safety planning, everything else they need to do right then and there. And so we try, you know, sometimes they'll want to pack up, move to the shelter. Sometimes they'll think, no, I'm okay, he's going to jail, I can take my time, I can go do it with family. Or sometimes they'll say, well, I don't even care and I'm not going to do anything. But yeah, so we're working with the victims, getting the victims in touch with the advocates at the moment.
I do. I wondered, with all the data and including the executive order from the governor, why do counties such as Spokane get their suicide prevention funding cut? That's probably a question for the Department of Health.
So it's a really good question, and it's ubiquitous. It's in the state, it's at the national level, and it's at the county level. I think what, for example, this past legislative session, recognizing that suicide is such a major public health issue, and that we are severely under-resourced here in Washington State. The Department of Health, working with all the Action Alliance for Suicide Prevention members, we put together a multi-state agency decision package to be considered by the governor's office and the legislature. So we're trying to get some of that funding that will then be extended to the counties as well. Some of the parts of that decision package were for services and for certain prevention strategies that would impact the entire state. But you touch on a very good issue. It is very underfunded. I have been hearing recently that there may be some additional federal funding coming out for suicide prevention. We're not seeing it quite yet, but we are eternally hopeful.
All right, other questions? Jen, do we have any questions from online folks at all? All right. Go ahead, Kara.
One of the interventions that you had on the board but didn't speak about was reducing or restricting access to lethal means. And is the Department of Health doing policy advocacy about gun control measures in Washington?
Thanks for that question. I want to tell you that when we were talking about the restricting access to lethal means, we are very much in support and working in the collaborations for safe storage. This is a big deal. We also, at the Department of Health, did support the extreme risk protection order this past year, and we watch and monitor the other bills very closely.
Is there anything in particular that's moving through right now that might be of interest that you can think of in terms of legislation?
So I'm a state official here, and I have boundaries. But yes, as you know, Initiative 1639 passed last year, and there are a lot of firearm bills, the most that I think we've ever seen going through the legislature right now. And they're all broken out. If you go on the legislative website, you can actually see all of the particular bills that are moving right now. So we'll see how that turns out.
Thank you. Other questions? Yes, right here.
Can you push your closest pod and ask your question into it?
Go ahead.
Oh, you have to hold it down while you're talking. I can hold it down there. Well, the question is, you talked about the groups that you have reached out to and how the demographics matter. People will use what they're familiar with as well as what they have available. You know, what's acceptable in their demographic group. So how come in your list of collaboration you haven't listed any groups of actual firearms owners? Because what they're telling each other is lie to medical personnel, lie to the VA, lie to a counselor, lie to the doctor. So you're not touching the other side of the equation.
So as I pointed out, the Safer Homes Coalition is working very closely with firearm retailers and hunter safety, basically working with the firearm owner community. It's actually been doing a great job across the state of going to gun shows and going to different sporting what do you call them, sporting shops and so on. So even though it may not be a one-on-one, it is working with the people who are directly buying when they come to the sporting shops and at the gun shows. But they're really focusing on the industry itself and reaching the industry itself primarily through that suicide lens, because while we're not talking about taking your guns away and we're not talking about the restrictions necessarily, what we're saying is that everybody can agree that we should do something to reduce suicides in this state and in this country, and we certainly should do something to reduce them by firearms, because we saw more than half of all suicides in Washington state are by suicide, and more than 75% of all firearm deaths in the state are suicide. So.
Thank you. Other questions? Kira.
Do we have any data on numbers on who is using the firearm to harm themselves or others? Because it seems like men are at risk of suicide, men are at risk of hurting women. The men seem to be the problem without, yep.
You can just say it. So, Kira, what was the question?
Do we have I'm wondering if there's a number out there that's 78% of violence with a gun is perpetrated by men, or not perpetrated, it's from a man.
I'll go back to some of my lifestyle things and raising a few daughters, and the saying around the house is boys are stupid, throw rocks at them. Boys are men, and it's just the stupidness really doesn't go away. Yeah, men are at higher risk for all those things. Jackson Katz, I don't know if you heard him, he was here in Spokane speaking earlier, talking about how violence is a man's problem, domestic violence is a man problem because we're the ones committing it. You go look at the mass shootings, 99% of the mass shootings are done by men. So yeah, there is a men-gun combination out there. And I know the stats on their website break down the males, the age of the males, and the males in suicide and the males in homicide. So yeah, it's a man thing.
And I think one of the slides that I showed was the firearm suicide and homicide by sex. Yes, and just to, you might want to take a look at that one again, but just to repeat that. In the United States, male suicides by firearm were 95,796 in the 2013 to 2017 period. And women were 15,575. In homicides, men were 54,185. Women were about 10,000.
Might help with Kira's question. So if we were able to take the lifestyle risk factors, which to me seem like if you're getting towards what's the cause of why people do this, and then associate that with gender, then it might show a pattern of why men are more likely to do this. Is that kind of what the question that you're getting at, right? Like, why is it that men are so likely to want to use a firearm either to kill themselves or to inflict domestic violence on another, most likely a woman? Would that be kind of where your question's getting at?
Yeah.
All right. Because there would be the reason to intervene. And I saw a lot of that when you were talking about like trying to draw people away from isolation and like creating happiness and reasons to live that maybe are slipping away from males in this country. I don't know. Possibly.
So as I was mentioning, the National Violent Death Reporting System is a drill down into circumstances and characteristics of these violent deaths. It's on 26. Let's see, 26, maybe not. Right. Oh, So let me just show you this. In looking at the circumstances, there are 666 characteristics and circumstances in the violent death reporting system that our team of data abstractors pull from medical examiner and coroner and law enforcement reports. Again, it's the new system to Washington State. We are thrilled about it because it will get right to the heart of what you're talking about. Let's look at really detailed into the circumstances. This is just a smattering of what we have looked at so far. Again, it's limited data because it's only 2015 and 2016 only in some counties. But we have, as I said, 666 of this. And you will see, I think I might have it on another slide that I had to fly over. It's very, very clear where there are stressors and where there are relationship issues, where physical health, we're seeing an uptick in the older adult suicides. And when we go across this graph with respect to older adults, we see the physical health problems there. So as our data system here grows more robust in Washington State, we will know a heck of a lot more. It's, like I said, it's really exciting for the state and will drive prevention and will negate prevention, strategies that we're doing that aren't making any difference. Again, we are really evidence-based, so to get to the evidence base, we just have to keep marching that way all the time, which sometimes will require us to say, whoop, wrong way, let's go this way. So that's what we're looking forward to with the system. So I appreciate your question. I encourage you to watch the violent death reporting system as it evolves and take a look at it on the United States level. It was a phased implementation across the U.S. And some of the states like Oregon have been in since 2002. And so they have a very rich history going on there. We were just notified by the CDC recently that now we have enough data in Washington State that we will be a part of the national reports that come out, but they're very slow. They take some time to get there.
Hang on a second. Let's have Charlotte and then Thomas.
So you mentioned isolation as a risk factor for suicide. I was wondering, is that on an individual basis or sort of community level, like rural areas have higher suicide rates? And then what is the, are there possible responses that the state's kind of come up with to try to mitigate that?
Yeah, really nice question. Yes, it's across the board because whether you live in an urban area or a rural area, it depends on what's going on in your world. You can have be very isolated. Isolation in the rural areas is definitely a high risk factor, and we see this. And then what are we doing about it? A piece of what we're doing about it is bringing together all of these collaborations that we're talking about, whether it be your faith-based communities, whether it be your community centers, whether, I want to show you one slide. Let's see, where is it? It's down. I want to show you something out of Parkland here. Let's see, is it down? Right there. Oh, that one right there. We have, I just want to show you this because this is going on in Parkland. They were just going to, they were going to open this this community wellness center in, I think next month. Because of what just happened in Parkland, they decided to accelerate the opening. They are basically putting together the community wellness center that will bring together and be a place for everybody to join together. So that's some of what's happened in Washington State. We have a lot of different activities. For example, we are working with what's called the BRE Collaborative. The BRE Collaborative was a legislatively created body, and they are looking at, they issued a suicide report in the primary care primarily arena. And that was basically to help physicians and other clinicians basically recognize isolation, recognize what's going on with people who present to them. Again, you have to come into the clinical system in order to be identified. But those are all really important strategies. We just are really working on developing this piece of it. When we wrote the suicide prevention plan, like I mentioned, it was the first across the lifespan suicide prevention plan. Our primary premise in it is that everybody plays a role. So it's you, it's me, it's the person at the store who you may encounter, and then it's all the other pieces as well. So this is a really important part. And one of the statistics that I think I showed you is that a huge amount of firearm deaths occur at a home. And so that's a lot of intervention there. You need somebody to know, to be able to recognize that they should be aware, they should be listening, whether it be your friends, your roommate, your family, parents, everybody. So we're working on all those pieces.
Would it be useful if our MPH students poked around in the Washington data set and started to do like correlation studies?
I recommend that you poke around and poke around and poke around. Yes, please. Yes, yes, it's just great. Yes, absolutely. I think you should. It's there's a lot of good data there, and we have gaps. One of the things that we're just bringing on board now is the legislature required 2 years ago that all emergency departments report to the Department of Health. So we're building another database there that we've started to look at. It's kind of messy right now, needs a little bit of work because they're building the system, and they're doing a great job with this, but eventually that data will also be available. So when we're going across the continuum, we can learn more and more and more. So yes, I encourage you to poke around as much as you can.
2 questions. One real quick. On the slide, it said your name ended in E. Is that correct, or is it an A at the end of it? It's an E.
Therese.
Okay,
yes.
very good.
Okay.
So my other question is...
I was going to say I've got an E and an A on both sides of it.
Then my other question is, you said you're partnering with the emergency rooms, and all coroners are partnering with you too?
Oh, so those are 2 different systems. We have we're building emergency room data now. We have a Department of Health database. It's called Rhino, and we are now getting ED data coming in. The other system is the violent death reporting system that I was talking to you about, and that is a system that pulls death certificates. We start from a death certificate, and then we key from that death. It is denoted as a violent death. We take that, and then we go to the medical examiner or the coroner, depending on which is in the seat in each county. We get the data there, so then we have the death certificate. We pull the file from the coroner medical examiner, which makes it richer. And then if it involved law enforcement, then we get their file and we look at that whole picture. So the whole idea is to link everything together. That system also links, as Officer Ferguson was talking about, it links situations where you'll have a murder and a suicide or gang-related incident. So this is something we haven't had in Washington State previously, so it's new.
Medical examiner does not classify it as a suicide.
Oh my word, oh, that's a long discussion. It's a really good question. It is, what do we call them? Opportunities to educate and to learn. So I appreciate that question. It's a really important question. And I will tell you, it comes up every 5 minutes in my office when we're talking about the violent deaths. So the system is strengthening. We're doing, when we communicate with our coroners and our medical examiners. We developed a checklist, basically, but there are just some things that the Department of Health doesn't actually control. But we can educate, and that's our job.
Wonderful. Well, thank you all for joining us on this Friday afternoon and giving us a little bit of your time. This presentation, if you want to review it, will be posted on our YouTube channel. You can search it EWU MPH and find all of our Grand Rounds archived there. Our last one is next month, April 26th. We will talk about Medicaid transformation. And for anyone who has anything to do with serving the underserved or working in clinics, what we're doing with our Medicaid dollars is innovative and it's going to affect us all. So we will have Sharice Pope locally from our Better Health Together, who's involved in our local ACH, overseeing that process. And we also have Maria Corriganos, who will be coming in from the state to talk about the overall state approach as well. And then that's going to be it for us for the year. Again, thank you so much for being here. You will get an evaluation form, so it's your last chance. We're going to decide our slate of subjects for next year, so we're hoping to unveil them at our next presentation. So please take some time, fill out the evaluation, and give us your topics and what you think we should cover in our next round of Grand Rounds. So thank you all for being here, and have a good evening.